What if the problem was never behavior, but the brain behind it? Dr. Monique Chouraeshkenazi explains how trauma and survival wiring reshape decision making, and why veterans and first responders are often misunderstood because of it. Pressure changes people. Prolonged pressure rewires the brain. On tonight's episode of Tactical Tequila Podcast with your host, Matt Wilson. If you enjoy the show, hit the like button, subscribe, and share it to your social media platforms. Thanks for tuning in and enjoy the show. Welcome back, everyone. Matt with Tactical Tequila Podcast here. And tonight's show, we have another amazing show on mental health and neuropsychopathology. And Dr. Mo is back in the house. Pressure changes people. Prolonged pressure rewires the brain. Dr. Monique Chouraeshkenazi works in the space where trauma, impulse, and accountability collide, where neuroscience meets courtrooms that often misunderstand the very organ driving human behavior. Tonight, we're going to break down what happens when survival wiring, built-in combat, emergency response, and high-stress environments is judged by systems that were never designed to understand it. From veterans and first responders to the legal consequences of brain behavior science. This conversation pulls back the curtain on what really happens when adaptation gets mistaken for dysfunction. This isn't just a theory. This is science behind the behavior that strikes when the stakes are real. Dr. Monique, welcome to the show.
Thank
Again.
you. Be back. I appreciate it.
So since the last time you were on the show, you have come out with your new book series. The core themes behind it are brain doesn't equal behavior. When does mental disorders preclude from criminal responsibility, and how trauma can change the brain? Just to kind of give it a little summary there. And deep down to its core, it goes along the lines of some people don't break the law because they're evil, but more or less they break the law because something in their brain is broken. Can you dive into that a little bit more?
Sure. So first I will start with what forensic neuropsychopathology is and how it came about, because to have that context will make it all make a little bit more sense. I know it's a long word, and I've done videos about explaining what it is as well as the definition, but I would say back in 2020, when I was working on my doctoral program in clinical psychology, that's when I became interested in neuropsychopathology, because the degree I got before then, I was studying the psychopathology of combat veterans that came back from Iraq and Afghanistan. And I think I briefly discussed that with you when we talked last year about how most of the veterans that came back, the combat veterans that came back that were exposed to trauma in combat, were diagnosed with either traumatic brain injury, major depression, or PTSD. 50% of those who came back and were diagnosed, they were either dishonorably discharged or medically boarded out due to committed crimes that were related to violent crimes. And that's what gave me the interest. Hey, that's what I want to talk about when I'm working on this doctoral dissertation. Talk about neuropsychopathology, because it's just more than mental health issues. It's a large part of it. But what people don't realize is when you have a mental condition and it goes undiagnosed or misdiagnosed or untreated, it totally impacts cognitive and brain functioning. And that's what causes the issues that lead to the legal system. So to not talk so much about that, but fast forward after I did the program and I was working on the dissertation, I was focusing more on the science behind brain behavior and the legal system. So that's how forensics became involved because you got to look at the science behind it. You have to look at the criminal justice system and the implications when dealing with mental health conditions. And what does that mean for the American legal system? How are we fighting between not weaponizing mental health and brain behavior, but at the same time holding people accountable who do have mental health conditions, but that was not the reason why they committed the crime. So that's why I delved deeper back into forensics, and that's how forensic neuropsychopathology came to be in a short story. And so when you're dealing with neuro, I break it down: neuro, brain, psycho, mind, pathology, disease. So we're looking at the disease part of the brain that impacts mental health conditions. And what I've found in the 5 years of research of working in forensic neuropsychopathology is there are actual brain regions that change due to mental health conditions, which changes your behavior. And that's located in our frontal lobe, particularly the prefrontal cortex, that's responsible for decision making, judgment calls, rationality. All those things are impacted that we actually need part of our executive functioning skills, which is responsible for higher executive learning, like organization, planning, judgment again. And that's when I noticed that, okay, this is the gap in mental health. We discuss psychology, and there's totally a bunch of subdisciplines of psychology. You have cognitive psychology, experimental, you have forensic psychology, and you even have clinical neuropsychology. But I felt like forensic neuropsychopathology need to be added because we really do need to focus on the brain behavior relationship and how that impacts not only mental health conditions or how mental health conditions impact the brain, as well as what are the implications for the legal system.
So now, at what point would abnormal brain function cross from being clinical to a concern into a legal one?
So there's, I would say, a variability like in that because there's so many different factors how it becomes a little legal problem. But I can give you an example. Let's say there's a person that has a history of mental health condition. Let's just say that they were, diagnosed with PTSD. And then, they're getting treatment. It might not be comprehensive treatment or the right treatment. But when you're dealing with a person with PTSD and they start to have episodes, things that will cloud their judgment and their emotions and their behavior, and they end up committing a crime, they get arrested. We all know when a person is arrested and they're charged with a crime, it'll always come up, well, this person has a history of mental health. That's like the first thing that comes up. And that's how we know after the fact that they committed that crime, that they have a history. So now we're doing a comprehensive background that person's medical and psychiatric history to determine what was the propensity for them to commit this crime? Was their mental health condition a component in committing this crime? If it was it significant? Was it the main decision factor in that person having, committed that crime? Because there's so many different components to PTSD. One of them can be psychosis. So let's say the person with PTSD has a psychotic break and they rob a store and they accidentally shoot the owner. Now we're looking at criminal responsibility. And then you have to determine the criminal responsibility by looking at all the factors of their history, which is important. And then you really have to have expertise to make clinical opinions and clinical judgment to determine if that mental health condition was a significant factor in that person committing the crime. So that's how it becomes, intertwined with the legal system.
So now, who should ultimately have that decision to decide that factor, or who does?
when it comes to the expertise in determining that factor? Or
More or less deciding that boundary in between the clinical side and the legal side.
so it all depends. Let's say the person's in a trial, right? And they're going up for the crime that they committed. The court will deem whoever has the expertise as the expert witness to give that clinical opinion. And more than likely, the person that's given that clinical opinion has seen and evaluated that person and has looked at their comprehensive background to determine the factors, look at the case. They also have to have experience with the court system and the law too, because in terms of giving that clinical opinion, they have to relate it to the legal justice system. That's why the court has to determine if that person is an expert witness or not and can attest to that. They also have fact witnesses that can only attest to what they know about the person that's being accused of a crime. But that expert is going to give that clinical opinion to the court to say, based on what they know, their training, their education, looking at the case, what is the propensity of this, you know, condition of this person committing the crime, it being, you know, the majority of the factor in that person committing the crime, where criminal responsibility is really a high factor in that situation.
What would you say the biggest myth that the courts still believe about how the brain actually influences the behavior?
That's a tricky question, a good question, but a tricky one, because with it being myths, I don't know if it's necessarily a myth more as it is not having the understanding about the complexity of the brain and behavior that causes people to commit crimes. Because we're so much focused on the mental health condition, we're not focused on how that conditioning or that condition is impacting their brain and their behavior. So I feel like that's the gap. That's the limited information that's within the criminal justice system. And I feel like if we focused on it all, the system, the brain, and the mental health condition, there'd be more clarity and understanding about how the brain has changed and making that person making those decisions to lead them to the legal justice system based on their acts.
Now, how do we get the system caught up to where we're at?
Well, that's why I'm here. That's why I wrote the book. Because I realize it is a problem. Just doing those two research projects, I realize how much that is a problem. We have so many experts in this country, and they all have their expertise when it comes to the legal justice system, when it comes to, every mental disorder that's delineated by the American Psychiatric Association. We just have so many experts, but we're not working together. And that's why I created that book. That book is basically like the foundation of what needs to be done. Now, I'm not the expert in everything, and that's why I implore experts to read this book, because I want us all to work together. It needs to be a collaborative effort. That's another gap that I see when it comes to the system, because medical providers, such as, your general practitioner or a specialist like a neurologist, we're not talking to each other. And I'm just a clinical scientist, and I have the information to provide, but they don't know that they need it. And so when I was doing my clinical training and I was actually seeing patients, I made an effort to talk to medical providers, to attorneys, to prescribing providers like psychiatrists that are prescribing psychotropics. I made a point to have collaborative relationships when we all had a patient in common, so they can see how different things are driving this person's behavior.
In that instance, do you think that we will ever get to the point where everybody's on board within the collaboration, or um, is this something that's going to continue on and it's going to take, you know, 20, 30 years for them to catch up?
Well, I believe it's already started. And I think, well, yeah, there's definitely improvement that needs to be made in these collaborative relationships. I think it has started, but I think it's going to take some time, as we see a shift in our economy, we also see providers downsizing. Like what I've seen now is medical providers, more practices, private practices are being closed, and now they're becoming partners in medical groups. That's a start. Medical groups are larger. So you can have collaborative approaches when you're having a community of doctors that are working together. But now we need to work with scientists. We have to work with researchers. We have to work with nurses. We have to work with, like I said, prescribing providers. Everybody needs to work together. And I think that's the issue. They have the interdisciplinary approaches, but we need the multidisciplinary approaches. We need the different fields to work with each other. And that can happen. It's just going to take some time, but spreading awareness about this issue, that's what's going to be most important.
How does the book challenge the idea that mental illness nearly fits diagnostic labels and when applied to those real world legal cases?
So, in what aspect? Like, what do you mean? I want to make sure
Um,
I hear it correctly.
because there's you're correlating both the clinical side into the legal aspect. So how does it challenge the idea of the that mental illness nearly fits into like diagnostic labels? How does it challenge that? Because I would say that with the current system, and even the past 10 years, in the current system that we have, I feel that there is this label where mental illness just fits into a box for the system.
I see what you're saying.
So how and I'm sorry that it I went the long way around in getting to this, but how does your book challenge that mental illness doesn't fit into a specific box?
Well, another great question. I would say, well, the series is broken down in 3 volumes. The first series is based on the research and science behind the discipline, and it talks about all of the different fields that are involved in forensic neuropsychopathology. The second book talks distinctly about mental disorders, and it focuses not only on every mental disorder that's in the American Psychological Association's diagnostic book, but it focuses on sociopathy and psychopathy. The third book focuses on legal implications, law enforcement, critical access teams of that nature. I would say all 3 of those series challenge a broad perspective that even though mental health is an illness and a disorder, some people don't like it to be fit in a box to be diagnostic. And for example, there's certain therapies where therapists are trained to acknowledge that we don't label the illness or the mental health condition. You focus on that person and that person's personality and their ways of life. So, I mean, it's a tricky question because we're not supposed to fit it in one box. It's not meant to be that way. However, in order to be definitively diagnosed with a mental disorder, you have to be labeled and you have to have, you know, clinical diagnosis based on a diagnostic code. My book it doesn't really challenge it all the way. It just holds accountability when we use those diagnostic labels to try to get out of a criminal activity. And I think that's what you're asking, or is that what
Yes.
basically what you're asking? Yes. And that's what the third volume discusses. Like, yes, I totally believe a person that is severely mentally ill has a history and they committed an act under an episode that deems whether they can be, competent, insane, or have criminal responsibility. That's a totally different situation and they need to be rehabilitated. But then when we're trying to use that label to say, oh, I had PTSD and I murdered my family, No, now you're weaponizing mental health, and that's what I don't agree with. So on the both ends of the spectrum, my book challenges, but it also supports it at the same time. So I hope I answered your question in that
Yes.
context.
So, and when it comes to judges, attorneys, juries, what do you want them to truly understand about the brain based concept from your book? And which would most change courtroom outcomes?
I love that question because definitely what I want legal teams, legal professionals to understand is having a mental health diagnosis. You know, treatment can definitely help, but it's only as good as the person who's providing that treatment. And it's only as good as the person who's willing to accept the treatment, be consistent with it, and stay on the regimen, which it's either medication and therapy individually or combined group therapy, something to show that they're trying to improve, because that's going to be the issue with brain behavior and mental diseases. If it's not treated, I call it a cognitive decline, because if you're not treating your mental health condition, you're going to eventually decline. Your brain is not going to function at the level, at its peak level, because you're not being treated. And then you have other factors that go on that impacts your brain functioning, whether it's a medical condition, stress, just typical things that we deal with on a daily basis. In addition to an untreated diagnosis, it can impel your brain activity and over time make those changes. And I think that's what the court system really needs to know about that. It's not just based on mental illness, it's also based on how it impacts the brain and how the brain functions at the time of, committing any type of criminal activity.
And you kind of touched on this just a little bit ago. From a neuropsychopathology standpoint, how flawed is our current understanding of intent?
Ooh, another good question. Flawed intent. Well, I think the misunderstanding becomes with competency and insanity. And intent, can it be in those? I guess it can be, because when we're testing for those things, and this is from a forensic standpoint, you have to understand whether a person is malingering or fiending. And that's what we're talking about, being deceptive or dishonest to try to get out of a criminal act, and not be held liable. So that's where intent comes from. If we have a person that's deemed to be lying, to be deceptive to get out of a crime, that's intent, whether the person has a mental disorder diagnosis or not. However, if a person is not being deceptive or dishonest and they committed a crime at the time of being, I wouldn't say under a diagnosis, but have a diagnosis and something, one of those symptoms at the time was responsible, then you're looking at criminal responsibility and competency issues. Is intent an issue there? More than likely, no, because if they're not criminally liable, if they were insane at the time of the crime, or when they're going before the court and they're not competent to stand trial, then there's really no intent. There's no motive, because at the time they were legally deemed not responsible for their actions. I think the intent comes more from if a person's trying to be deceptive and they're using their diagnosis with intent to get out of a crime or not be held responsible for
Do,
a crime
do you
committed.
think that that happens more often than not?
Oh, yeah. I think it happens more than what we know. We see a lot because we see those high profile cases, and we see the in those crimes that people will use their diagnosis to try to get out. But on the normal setting, I think it happens more often than not, because that's what, if you don't want to be held liable, if you don't want to do jail time or prison time, what's the first thing you're going to do? If you have any inkling of having any type of mental health background, you would try to use that to your advantage. And I just feel like that's instinctual for people to do that, because one, if they know that they got to do time regardless or not, depending on the crime, if they use that mental health aspect, they think that maybe they can get out of it, or, the time can be lowered. So, yeah.
Do you feel, or do you think that the brain can simultaneously explain behavior without excusing it?
Simultaneously explain the behavior without excusing it. The brain is such a complex organ. I would say through testing, and when I say testing, I'm talking about neuropsychological, psychological testing. I'm talking about neuroimaging, comprehensive medical evaluations, neurological evaluations. Those are the type of tools that are used to determine whether, what you're asking is deemed to be a factor in that. That's what I was trying to say. But yeah, those tools are important because, again, people with mental health diagnoses, some of them have never had a history of testing. And if you don't have testing, there's no baseline to see where your brain is currently functioning. And that's why, like, I always talk to people who have been in treatment for years and years or even months, and they're like, I don't feel like I'm getting better. Well, have you been tested? Because you might be getting the wrong treatment. If you're tested, you can have, definitive information to tell you what's going on with your brain, to tell you what's going on with you psychologically. And based on if there is any diagnoses, there's recommendations. So, definitely a complex situation, but it can be handled. And that's where I feel like people can better understand their brain and brain activity through those tools. And I think neuroimaging is the most important because the neuroimaging is going to tell you where things lack, such as, blood flow, electrical activity. Neuroimaging is going to tell you more information about that. Neuroimaging is like, I would say, in supplementing with testing, the neuroimaging to me is the most important because if a person has a diagnosis, especially something like PTSD or major depression or schizophrenia, there's certain parts of the brain that's going to be highlighted to say, hey, you diagnosed this person with schizophrenia, for example. Their test shows that they have hypofrontality, which is correlated to schizophrenia. So I think those are the things that are more important of what the brain actually tells.
How often do you see trauma driven brain adaptations misinterpreted as character flaws?
Oh man, when when I used to do testing, um, I would always see PTSD and personality disorders mislabeled as a person who's just, you know, I wouldn't say a train wreck, but a person who's a difficult person in society. And it's mainly the veterans. When they're out of the military, I've dealt with a large population that was diagnosed with PTSD. And if you don't understand the disorder, if you don't understand the symptoms, you're not going to understand the person. So me understanding and dealing with that particular condition for so long, I can see how people would look at these people and say they're difficult and just think, oh my gosh, lazy, annoying, irritable, lacks judgment, not productive at work, but they don't understand the symptoms. So when you don't understand what a person is going through, you label them as a bad flaw or bad character. And, a person with a mental health diagnosis, they're trying to suppress it. They don't want anybody to know because of the stigma of having a mental health condition. You know, you, People feel like they can't get certain jobs. A lot of things are impacted. And then if you have to be on medication, well, that's another thing. So I see it all the time, and it's mainly with PTSD. It's mainly with personality disorders, but I would say people, um, especially in the workplace, when it comes to work performance, a lot of people are mislabeled as lazy with those who have ADHD. That's a big one. And that's always correlated to academic and work performance, where a person's come to see me that needs to be tested, and they're telling me about all the things that their coworkers or friends or loved ones said about them not understanding what ADHD is. So I think that's another thing in spreading awareness. When you're dealing with somebody who has a mental health condition, try to learn more and educate yourself before judging them because, yes, there's character flaws, there's certain traits that can be annoying, but at the same time, if the person's not treated, they can't help it in certain aspects, especially to a certain extent. So
Everybody is dealing with something. That's why
everybody's
I,
dealing with something.
you know, that's why I always try and treat people with dignity and respect, and niceness, because you never know what someone's going through, and honestly, they could be having the worst day, and you're, for lack of better words, a shitty person to them, and now that triggers an episode where they go home and they attempt to take their life. Like,
Exactly.
it's unfortunate the way that we have become in society, dealing with people. And I think in maybe the last 10 to 12 years, we have become so afraid of hurting people's feelings. I think it's unfortunate that we as society have got to that point.
Hmm.
Um, but also, you know, being able to be nice to someone on a daily basis, just because you never know what they're going through.
Well, that takes character to be nice to
R-
someone
Right.
daily. But the
Yeah.
time frame that you just gave, COVID,
Yeah.
isolation, lack of social interaction, I think a lot of those things in that well, I won't say 6 years because now this has been 6 years since the beginning of COVID. But I think during that time frame, you got to think about kids that were developing that were forced to learn from home, um, people who were isolated and, working from home as well. You get so used to working in those environments. When you have to go back, it's different. And even a lot of companies now still do work from home. So now when you're 3, 4, 5, 6 years into working from home and then you're coming back, you don't know how to interact with people anymore. And then how your environment within your home, how you all treated each other, how you're going to treat your coworkers and people you don't know. So I think that had like a lot to do with how people treat each other now because it's certainly different. Like I've never experienced anything like this pre-COVID, the way the world is right now.
And that kind of just segues into where I want to go next is dealing with veterans, first responders, and even just operational trauma. How does repeated exposure to high threat environments neurologically rewire veterans and first responders in ways that civilians can rarely grasp?
You know, Great question because I look at first responders and law enforcement. The way I look at them, and I know this is probably a bad analogy, but it's like military on crack because, like, we're in the military and we're serving, but we're only in combat when we're deployed, right? We're usually in garrison until something occurs. But emergency responders and law enforcement are doing the same thing every day. Every shift that they go to, they're going to see something. Maybe they'll have a good day and have something minor like traffic tickets. But when their job is to face trauma every day, they're going to, either see a shooting, a drive by, get shot at themselves, respond to high threat cases. And that's where the majority of them, they experience complex PTSD. And the difference between the two is complex PTSD is like more like being immune to the trauma because you're exposed to it so much. Like you're exposed to different scenarios, different forms of trauma on a daily basis. It definitely rewires your brain. There's so many cops that I've talked to. I actually went to a conference when I was in Las Vegas last September. Uh, Yeah, I went it was a law enforcement conference, and speaking to a lot of them had retired, and the things that they were exposed to, I can't even imagine. It was like listening to them, and they were on a daily battlefield every single day. And it's like, how do you turn that off and come home to your spouse and kids? How do you separate from seeing somebody's body parts severed in the highway due to a major crash and then come home and eat dinner? Those were the things that I was like in so much shock and awe. It was mind blowing listening to what they experienced. And, the majority of them got treatment. And I don't want to say when it was too late, but we're talking about people who had been cops for over 20 years getting treatment at the 18th year after they've been exposed to so much trauma. A lot of them become immune, emotionally distant, withdraw, isolate, because they don't want to put all that on their family. So they choose to disassociate from them, distance themselves, and then you have to think about you're not getting treated. Only thing you're doing is protected and serving, protective and serving. So you're not getting treatment because of the stigma. If I go to treatment, they're taking my badge, they're taking my weapon. This is how I, survive and support my family. So no, I know something is wrong, but I can still get up and do the job.
Well,
And
and sorry to interrupt you,
go
but you know, I've had a few guests on the show that are one was a police chief, another one she's a female sergeant out of New York, New Jersey, and they have implemented and well, the one's chief and then the other chief, they've implemented mental health aspects into their department. So if you're involved in an officer shooting or a serious incident, then they say, okay, look, whether you want to or not, like go talk because it's going to affect you. And
Mhm.
not only is it going to affect you, but now it's going to affect the officers around you because of how you may treat them, or something like this could trigger you to just stop in your tracks if you see it again, because now you're dealing with that trauma that you never got diagnosed or never sought treatment for.
And I will tell you this, most of the police departments that I've dealt with, heard about, research, even the cops that I talked to, it seems like they all have mental health, you know, programs in place. But it's only as good as the cop who's willing to participate in it. Yes, after a police involved shooting, it's mandatory that you go. But what are you taking from that? Right? Like a lot of them just do the bare minimum of what they need to do to get back on the job. They're not really making this a commitment to say, hey, I really need treatment. Let me go and continue to see therapy and continue to help. I will say that the majority of the cops that I met with, they're all in therapy now that they're out, now that they're retired or they were medically retired. I don't hear a lot of them saying, "I'm actively getting treatment while I'm on duty." When do you have time when you're working 12, 14-hour shifts? Then you have to stay physically fit. Then you have a family and you're on call. A lot of them will put it to the side because they're like, "I take care." They'll keep pushing it and not knowing that the more that they push it, the higher chances of something catastrophic happening mentally or psychologically to them because they're not getting the help, they're not getting treated. And that's where I've seen a lot of them fall short. The stories always end with, oh my God, my dream job, I moved up the ladder. But now the shifts are longer, the cases are more dangerous and complex, and they just put their mental health off because they got to be strong, fit to fight. And if you deal with mental health, you're weak, right? If I tell you I have a mental health problem, does that make me look like I'm like a strong leader in law enforcement?
Well, and I think that it's starting to become more prominent now that officers are recognizing it, and
Yes.
um,
I love about it. Yes.
they're more likely to deal with it now than 10, 15, 20 years ago. Be-
Exactly. I totally agree
because
with that.
because you had that stigma that if even military, if shake it off, like walk it off, like
Mhm.
if you're dealing, then you're a bitch, or what have you. And it's like, okay, but how am I going to be fit for the fight if I'm not taking care of my brain, you know?
Exactly. I do agree. They are definitely getting better with their programs, but like I said, most of the ones that I encountered, I'm talking about ones that had been in 20, 30 years, and you gotta think back in those times, n nobody's talking about mental health at those times, but I'm glad it's being talked about now, and I'm glad that they're implementing better programs for their officers.
How would you say that so many veterans and first responders get misdiagnosed when their symptoms are actually neurobiological adaptations?
I would say in a sense because when they're getting diagnosed, they're one, probably not getting tested, and two, nobody's looking at that aspect of it. When you're thinking about somebody who's getting diagnosed with a mental health condition, most of the time, what I say generally is supposed to happen, get them tested first to see what's going on, and then they get the appropriate treatment. But then people realize, like, mentally, I'm not okay. Psychologically, I'm not okay. I need to go to therapy. So they automatically just go straight to therapy. And based on that encounter, that initial session, that therapist or that psychologist has to give like a provisional diagnosis the first day that they meet them. And that's based on what they talk about, the symptoms, the history, that provisional diagnosis. And as they continue to see that person, that diagnosis can change. Now, when you're dealing from that aspect, you're not looking at neuro related issues unless somebody says that they experienced like a traumatic brain injury or concussion or was in a bad accident where they probably got rattled. And now we're looking at it from a neuro related standpoint. But most of the time, that's not the case. And when I was even in school for clinical training, I realized that that wasn't the case. People were going directly to therapy, getting treatment, but not getting assessed to determine, hey, is this the proper treatment for this person? And I think that's a major problem. That's what we need to work on standardization across the country. If people want to get therapy because they experience mental health issues, get tested first. That way you know what's going on with you and you can get the proper treatment following instead of doing it backwards, going to therapy or treatment. And now you have to get tested because all this time has gone by and you're not improving or getting better.
Now, and so with that, the VA is wonderful at this. That they and I'm being facetious when I say this, um, but they you if you ask for certain tests, or it's like red tape trying to get them to bless off on anything. How do you see instances like that when it's so hard for veterans coming out to get the tests that you're talking about? What is a good route that a veteran could take in order to get the VA to say, yes, you know, we'll do this testing?
I will say one that the VA system is definitely oversaturated, and that's why the system's so clogged. And I will say that they don't have sufficient military psychologists to assist. And I can say that firsthand because when I was doing testing, they were literally making referrals to the practice that I was working for. And I was doing those referrals because, and I'm talking about even active duty. I'm not just talking about veterans. I'm talking about TRICARE sending active duty because even they don't have sufficient military psychologists that can do the testing. So I would say in that aspect is oversaturated, but what a veteran has to advocate for themselves, and it's so important because if they don't, they're not going to get the things that they need. And I would say any person who's about to retire or separate from the military, they need to start their VA process while on active duty. I feel like that's the faster way, the fastest way that they can get the assistance that they need instead of waiting until they're actually out and then trying to get into the system to get tested. But that's the thing too, when you're going through the claim process, when you're getting out and you're becoming a veteran, they're supposed to test you. And I can tell you, I got out almost 11 years ago. This year makes 11 years. They didn't test me.
Nope.
They didn't test me. And you know how I know? Because when I went to training for clinical training, the practice testing, I was like, they didn't do this for me. Like I never went through, I think I probably did a mental health screening. It wasn't an actual psychological testing because I would have remembered when I was doing it in training. So I don't know actually what type of testing they do. I just know that they do screening. But I feel like that's the problem. If people know what their diagnoses are by the time they get out, I think it's easier for them to get the appropriate services by the people that they need. And if there's insufficient military psychologists, whether military or civilian, they need to have it in place that they could automatically refer these people out so they can get the treatment that they need. And I think that would be better. Have it part of the transition assistance programs for these active duty members that are transitioning to veteran status. Have it in place. Matter of fact, have it a part of that 2-3 week program. That way they already have what they need and they don't have to try to fight to get it once they're already out.
Can trauma physically reshape the brain in ways that permanently alter behavior? Would you say that recovery is always possible? Once diagnosed with a mental health condition, would you say that it's possible for them to recover from that?
Yes, there's certain conditions, it will always be there. It's just a matter of treatment. But when you're dealing with, I would say the more severe, like PTSD, yes, it's going to change the way you function because there's a lot of different components that affects other parts of your body, like flashbacks, nightmares. What does that impact? Sleep. We all know if you don't get sufficient sleep, what happens? Memory loss. The less sleep that you get, the more that you cannot retain. And that links to higher levels being susceptible to neurocognitive diseases once they get older. So even though we know Alzheimer's is a link to genetics, it can also be exacerbated or highly likely to a person who's dealing with long-term sleep loss that leads to other medical conditions. So you got to think of certain components like a PTSD, what a person is dealing with the most and what symptoms that lead to medical issues. High anxiety leads to depression. Depression leads to, you know, depression of your parasympathetic and sympathetic systems. That's what I was trying to say. Those are responsible. Well, the parasympathetic system is responsible for our resting state and calming and cooling. Our sympathetic system is fight or flight. If we're always in fight or flight and you have PTSD, what does that lead to? Heart disease, you're stressed out, you're overexerting. So you have to look at what people are struggling with and manage those. Those symptoms can definitely correlate to medical conditions and they will definitely impact the brain. However, if you are, receiving treatment, good treatment at that, they can be manageable. And then we have a term where we call neuroplasticity, which is a positive aspect of changing the brain over time on a positive set. So there is a propensity for people, if they're getting the right type of treatment, they're doing well, they have a healthy lifestyle. We're talking about healthy eating, low stress, exercising, doing your treatment for your mental health conditions. Neuroplasticity has the ability to change a person's brain for the better, improving memory and cognitive abilities. On a significant level, I can't say, but it can happen.
Now, you touched on lack of sleep. How
Mhm.
does medication affect that as well? So, like, if you're on sleep medication, and in order to let's say someone has PTSD, they don't sleep very well. They're on, stuff such as Ambien or Trazodone, medications like that. Long-term effect of those medications, what does that do to your brain?
You know, honestly, it depends when you say long term, because when we're talking about Ambien and Trazodone, we're talking about medications that you're only supposed to use as needed. If you're taking it every day and your insomnia is that bad, then that's a problem. I suffer from chronic insomnia and I take Trazodone and I don't take it every day because one, what I will tell you, it has no problem putting you to sleep. It's just when you wake when you wake up, the whole day is crappy depending on how much you take. Like for me, I take 50 milligrams and I don't like the feeling of having to get up at 5, 6 a.m. to go to the gym and I'm still feeling like I want to go back to sleep. That's not good because it's almost like I don't want to say it's counteractive or counterproductive, but if you're using a sedative to go to sleep and you're waking up still feeling tired, how are you functioning? Because I know I don't function. So if I take it, I know I have to take it no later than 8:30 p.m. to not have that effect. And that's why I don't take it all the time. And that's why my insomnia is bad too. But I rather run on 4 or 5 hours of sleep than use that sedative because that specific effect for me is enough to impede on, I won't say my judgment or decision making, but it definitely impedes on my ability to focus and be distracted. It's almost like having ADHD. You can't focus because you're so tired because you're groggy. Some people might say, oh, well, then lower your dosage. Well, lowering it to 25 doesn't do anything. I don't fall asleep. So that's the whole reason. It's all about understanding your body's chemistry. And that's why it's important that we have like this collaborative partnerships with these doctors, because the doctors are going to tell you about the concept of dosages, half size, half titration when you're titrating down your medication to wean off of it, or the half life of a medication. All these things are important and you need to know them when you're taking stuff like sedatives long term, the long term effects. I don't think any doctor that prescribes something like Trazodone or Ambien is going to say it's meant for you to take it long term or it's meant for you to take it daily, um, because they do have long-term side effects and they will impede on your brain at some point because then now your brain's relying on that to go to sleep. Your body's not naturally wiring to go to sleep on its own. So that becomes a problem. I have no problem, like I don't gatekeep. I have no problem. Like I've had insomnia since 2007 and I've been on different medications over time because when you get used to one, it doesn't work anymore. But I make a point not to take it every night, only really, really when needed, because I know every medication has side effects, but I know how it affects me individually. Me, I can't speak for anybody else and say that they experience what I do, but I'm just telling people this is what I experience. And as a scientist, I kind of overanalyze things myself, and that's why I do what I do. So I know that I won't become dependent on that to go to sleep. I need to naturally be able to go to sleep.
You mentioned earlier in the show about traumatic brain injury, or TBI. Why is that still so under-recognized in the legal and psychiatric evaluations?
That's an excellent question. And I honestly can't tell you why it's overlooked, but I can honestly tell you why I make it a point for it to be, brought to awareness, especially when I deal with somebody who has had, I don't care if it was a small head injury, like getting hit with maybe a volleyball or something. People don't understand the impact of balls or the impact of getting hit in the head. Just because you don't fall to the ground doesn't mean that something hasn't happened. And I'll give you an example. I'll keep this very broad as possible because this was like a very complex case. But I was dealing with a 21-year-old male a couple years ago that had, by the time I tested them, had multiple diagnoses. And it wasn't until the end of the evaluation that I found out as a teenager they had a head injury playing sports and was diagnosed with a post-concussive syndrome, which was very important for me to know because then it explained everything else. Traumatic brain injuries cause a lot of issues, uh, not only with the brain, but emotions, behaviors, and actions. And people, remember when you asked me earlier about mislabeling and people be mislabeled as bad characters? That's the same thing with a traumatic brain injury because when the brain is impacted, whether it's a closed injury or open head injury, it affects rationality. It causes mood disorders. Sometimes people who lose conscious, they start having memory issues. So all these things become factors. And if you don't understand what a person is doing, what they experience after a TBI, you're not going to understand how they are. And they need that testing and evaluation and assessment. And in this particular case, I'm like, did they ever have, testing and assessment after that injury? No. Did they ever have imaging done on the brain? No. Really? So as a teenager, this person was hit, went unconscious, went to the hospital, and was never followed up on. And now as an adult, went untreated for years and now has bad behavior, mood swings, memory issues. And now they have all these other diagnoses because of an untreated brain injury. Fascinating, right?
Very. Um,
However, if that person was treated at the time of that injury and followed up and had testing as a young adult, it could have been a whole totally different picture for that person.
with that, let's take that case where they have a traumatic brain injury. It goes undiagnosed basically. And now that they're an adult, do they do you see signs in cases like this where they may not necessarily have bad behavior, but it's just the neurological side where they're having memory issues and things like that? Is it ever just that point where it could be just memory issues, or does the bad behavior also have fall in line with that?
It's both. And I can revert back to this case too. This person committed a bunch of acts and not understanding, you could have thought that this person was a sociopath, right? I'm talking about disregard for rules and laws. Um, just certain things that was going on with this person. However, once I learned about the traumatic brain injury or the post-concussive syndrome, I went back and I dug in and I found the explanations, like looking at the neuropsychological part of the testing. Like we're talking about a lower functioning working memory. Working memory is what we use to hold information in our mind to manipulate it. And then a processing speed is how fast we're processing the information that we're encoding into our brain. Those scores were significantly low. The overall IQ was low for that person's age, even though they were intelligent. But that goes to show that how that brain injury impacted that person over the years, but not being treated. And when we're talking about behavioral issues, we're talking about defying the law, not listening to adults, stealing, all those different things that were going on. I'm not going to say, oh, we can't hold this person liable because they actually do know morally right from wrong. But however, that brain injury impacted that person as they were developing. The brain still wasn't even developed when they suffered that injury. And what most people don't understand is a full brain development doesn't occur until a person's up to their mid 20s. So you got to think about a teenager suffering a brain injury, and then as a young adult, still not old enough to have a fully developed brain. However, this brain has been damaged. It has not been treated since they went to the emergency room years ago. So this was a great example for me how a person morally knows right from wrong, but can they be responsible for their actions because they were not even aware that their brain had changed over time to allow them to have these behavioral issues, emotional issues, isolation issues. So that's where it becomes a criminal responsibility problem. Okay, they know right from wrong, but are they criminally liable because they were not treated? And a lot of things this person wasn't even aware of, like repeating things to me. And I'm like, we just covered that like 5 minutes ago. And I'm thinking it's intentional. I'm like, it's not even intentional. There's memory problems here. For a young adult, this is not good. So brain injuries definitely have an impact on one person's behavior and decision making. And I think that's something that's not stressed a lot enough because we're so focused on the mental health. We're not focused on the overall how it impacts our brains. So,
Now, I kind of want to go back. We talked a little bit about constantly being under stress as a first responder and military. How does that chronic stress alter the decision making circuitry over time?
so when you think about stress, you got to always think about the person's physiological activities always at an all-time high. When a person is stressed out, their system is always in fight or flight. When it's in fight or flight, we're always looking at potential medical issues, not just psychological, but medical issues, highly correlated to heart disease. So when we're talking about a person constantly being under stress, I remember studying for the psychology. Well, I'm still studying for the psychology licensure examination. And it says, I'll never forget the question, what are the one trait that's correlated to a person who suffers from chronic stress? Hostility. A person who is stressed out is always hostile. And a person who is always hostile has negative behavior, treats people negatively, treats themselves negatively, treats their bodies negatively. And that has a propensity to change how their brain functions over time. Because I don't know if you ever heard the saying, but if you always have negative things to say and think about, and that's all you think about, you can change the circuitry in your brain to always focus on negative things. So when you're in a highly stressed state and you're hostile all the time, you have the propensity to change your brain to you're always going to be in that state and you're always going to be negative. And when you're negative, it always leads to negative things. And when it leads to negative things, it can eventually lead to a crime if you don't get out of that. If you don't have a heart attack first, because that's one of the first indicators. And they say that law enforcement and emergency responders are the first ones to be linked to heart attacks and strokes over any other profession. Besides, I think dentist and I forget the special doctors, whether it was like a neurosurgeon or I forget the other specialty, but it's dentist, emergency responders, and law enforcement.
That's interesting that dentists would fall into that.
You wouldn't think, but they said dentists have highly stressful jobs, especially those who do dental surgery and they deal with is it endodontologist or odontologist, the ones that deal with surgeries and severe diseases of the mouth. They said those are two stressful type dental professions who are
Okay.
highly stressed out. Yeah, the more than you know, right?
Going back to the legal aspect of things and neuropsychopathology in courtrooms, why do courts struggle so deeply to understand the neuroscience without oversimplifying it?
Well, it goes back to what I was discussing earlier. It's hard to deal with in the courtroom because of the lack of knowledge. There's an informational gap there. And I feel like in my research, I found that informational gap. There's still an informational gap when it comes to mental health. I don't even think mental health is fully understood in the courtroom because you have to always think. I'm not saying that legal professionals have a bias against mental health, but like I told you, the weaponization of mental health, always using it as excuse to get out of a crime in the legal system, is highly disconcerting when people are trying to legitimately help people who are in the legal justice system that have committed a crime and they do need help and have mental health issues. It becomes very complex because I feel like it's overused so many times. There is a big bias and informational gap there. And I don't think that a lot of legal teams really understand the complexity of mental disorders. And that's why they have forensic psychologists to help and consult whether it comes to assessing those people or giving legal teams that knowledge and expertise to really understand mental health in the courtroom. We have those, but we don't have enough of them, just like we don't have sufficient psychologists in the United States as well. We need to have more of those. But when it comes to the brain is even more complex than mental health. So if you don't have an expert coming in there and consulting with the legal teams to understand, like, hey, we do talk about mental health, but let's talk about how mental health impacts the brain. That's that informational gap that I feel like the legal system is lacking.
Have you seen cases in your research where ignoring the neuropsychopathology has led to irreversible injustice?
Not in the cases that I have done. No, I haven't gotten that far. But I'm pretty sure it does exist. I'm pretty sure of it. I'm pretty sure that I've seen cases, high profile cases where that exists. Oh, Aaron Hernandez. That was the first one that came to mind because after, he committed suicide, they found out he had CTE. That's like a classic case of somebody having mental issues and having a brain disorder, but we don't find out until after the fact because CTE can only be diagnosed once the person is deceased.
Interesting. And I think you mentioned that on the last episode that you
I'm
were
pretty
on.
sure, and it's in my book too.
Yeah,
Those cases, like, I don't just touch on mental health. I like to talk on cases that impact the brain, and CTE is a complex diagnosis because, like I said, you can't diagnose it until a person is already deceased. So you look back after the fact. Now he's passed on. Now you're looking at all these things that made sense why he was acting the way he was, being involved in crimes and murders when he was this high profile football player. And they said he was like the best of the best. And you got to think he was playing football since what, middle school, all the way to pro. Brain injuries and that high impact on the brain, of course, is going to cause behavioral, emotional changes, stuff like that. And you see that over time. You see the brain related injuries, but then you can't diagnose it fully until after a person passes on. Yeah, quite fascinating.
well, Monique, thank you so much for being on the show. Where can everyone find you on social media?
Everywhere. Well, well, I'm on Instagram. My handle is my last name, Chouraeshkenazi. My handle is the same, Chouraeshkenazi, for X. And then I think it's the same for my LinkedIn too. And then you can find more information on my 3-volume series, Forensic Neuropsychopathology, Medical and Clinical Insights into Brain Behavior, Mental Disorders in the Legal System. I have my own author site for that, and that's on www.moniquemchouraeshkenazi.com. So that's where you can find me.
Perfect. And if they wanted to order the book, where can they get it from?
They can order it directly from my author site or Barnes& Noble and Amazon.
Awesome. Well, I thank you for your time. And honestly, I could keep going and, diving into the brain because it to me, it's a fascinating thing.
Very fascinating.
And in my line of work, being able to see people's ticks and understand why they do the things that they do, like it's to me, it's just fascinating.
Definitely. That's why I'm in the field. But thank you so much for having me again, Matt. I really appreciate it. It's always a pleasure being on your show.
Likewise, it's always a pleasure having you on. Well, thank you, everyone. Have a good night.